change defibrillation, its mechanisms, how it's different from standard defibrillation regarding placement, where it acts on the heart, and the different causes of patients to go into shockable rhythms, such as ventricular fibrillation and pulseless ventricular tachycardia. Because the ILCOR guidelines recommend doing vector change defibrillation for patients 18 years and older that are experiencing refractory ventricular fibrillation or pulseless ventricular tachycardia. Refractory means they've been in a shockable rhythm for 3 consecutive defibrillations. This is different from recurrent, because recurrent means the patient was in ventricular fibrillation, it was terminated, so they went to a PA or a systole, then it reoccurred at any point in the arrest. Different because it's not consecutive. So there's a prime distinction between refractory ventricular fibrillation and recurrent ventricular fibrillation. So we look at normal conduction, because to apply what happens abnormally, we have to always review and comprehend what happens under normal circumstances. So obviously, our impulses should come from the SA node, travels down to the AV node, goes down the bundle branches, and goes out to the Purkinje fibers. We have spontaneous depolarization at the SA node because we have the most amount of cells depolarizing at this time, so that's that beautiful automaticity. We have the ability to automatically create our own impulses. And this manifests on a normal, healthy ECG. Patient has a P wave, so you know the impulse is coming from the atria. The PR interval is within a normal length. That means it's taking a normal amount of time to get from the SA node through the atria down to the AV node. Your QRS is narrow, meaning the impulse is coming from above the ventricles, and overall there's contraction of the atria and there's contraction of the ventricles, which correspond to our heartbeat. That's what happens normally. But if we look, so 85% of patients that are in ventricular fibrillation or pulseless ventricular tachycardia have some sort of structural heart disease, which is crazy to think about. So out of 350,000 people that die every year in North America, only about 100,000 of them will actually be in a shockable rhythm. And that incidence has gone down over time because of our treatment options, such as calcium channel blockers, beta blockers, internal defibs. Those have all reduced the incidence of actually seeing shockable rhythms. And obviously, if you're in a shockable rhythm in the pre-hospital setting, you have a higher likelihood to survive. It's about 20% approximately. However, that increase in coming back goes down after the third defibrillation. So it takes a pretty significant drop. Okay, so if you're in the shockable rhythm and you've had less than 3 shocks, your chance of coming back is around 20%. However, if you have 3 shocks or more during cardiac arrest, your mortality goes up and your chance of survival goes down, obviously. And that's the point of vector change. It's like, okay, we've put so much emphasis and research into cardiac arrest and specifically in the pre-hospital setting, but not much has actually moved the needle in getting patients back and getting them to be discharged healthy enough to live good, normal lives. So if you have somebody in ventricular fibrillation, again, that's usually caused by some sort of structural heart disease, such as cardiac ischemia, ST elevation, MI. The vast majority of patients in ventricular fibrillation that get a ROS will probably go to the cath lab. And the impulses are obviously coming from the ventricles. So you have these multiple ectopic foci coming from the ventricles, and they're going with these re-entry patterns that can save out like wave-like signals throughout the ventricles. That's why it leads to the ventricles actually quivering. But if they're quivering, they can't produce any output, so that means the patients won't have any blood pressure, drop, they'll have lack of perfusion to the brain, they'll go unconscious, and eventually in cardiac arrest. So the heart is so metabolically active and needs sufficient amount of oxygen to thrive. In about 3 to 5 minutes, our cells start irreversibly dying. And what happens when ischemia is present, it starts opening up these potassium channels. So you get more potassium in the extracellular space, so the space outside the cells. Conversely, you get all this sodium and you get all this calcium into the cell, and this disrupts the DNA, this disrupts cell membranes, this causes cellular swelling, and eventually if the damage ensues and continues, this leads to acidosis, this leads to hypoxia, and this causes all this cell death, because eventually the cells are going to lead to cell program death, or they're just going to burst, like they're just going to die on their own. And everyone's like, okay, why we care about cells? Because groups of cells create tissues and groups of tissues create organs. And eventually what happens in the cells, if it progresses long enough, it'll destroy our organs. So this is why time is critical. So if we think very macroscopically, we defibrillate this patient. We know early defibrillation saves lives. That's why public access defibs became prevalent, and this is why there's a huge impetus to get a defib on the patient and hopefully defibrillate them into a normal rhythm that should sustain perfusion. So we do the typical anterolateral placement, and we have biphasic monitors, so that means it should go both directions. So if we look, we at least want to depolarize 75% of our myocytes all at once. So you have to have enough of your myocytes depolarized to hopefully, for one beautiful moment in time, you have no electrical activity. And hopefully something above the ventricles will take over, and this will sustain and bring back perfusion. So again, that's standard defibrillation. We start with standard defibrillation because it depolarizes the largest portion of our myocardium. It's quite effective. But the problem with it, after 3 consecutive shocks, maybe the patient needs something different. And again, after 3 consecutive shocks, patient's mortality goes up. So it's like we need a new treatment option. So as you can see here, this patient's in ventricular fibrillation. You can see it's chaotic, it's disorganized, there's no identifiable P waves. It's not like a typical organized P wave, PR interval, QRS, T wave. This is a pretty chaotic rhythm. And of course, because it's quite wide in nature, that means it's more responsive to defibrillation. Patients normally manifest with, of course, ventricular fibrillation at the beginning of the rest, but as more myocytes die, the amplitude decreases because there's more cell death, less cells to depolarize, and eventually this will degenerate into asystole if it's not corrected in a timely manner. So this picture is directly from the New England Journal of Medicine article written by Dr. Cheskas, who's one of the physicians at Sunnybrook Base Hospital and did the study, dose VF study, assessing the difference between standard defibrillation, dual sequential, and vector change. So as we can see, standard defibrillation, we have our current pad placement, and it's so paramount to actually have the lateral pad quite lateral to hit that appropriate portion of our myocardium. However, vector change just means you get a new set of pads and you have a new placement, and particularly it's in the anterior posterior section. So as you can see, this pad goes to the back, which you can see here, and the lateral pad actually moves more to the center right over the heart. So it's kind of like a sandwich. And this is to apply a different vector because, again, if 75% of the myocardium at least needs to be depolarized, and it's still not depolarizing enough after 3 shocks, it's like maybe the problem is that we're not generating enough energy to the right part of the myocardium. So all these different research articles have demonstrated that the problem if patients are in refractory ventricular fibrillation, that 50% of them won't convert, which is a substantial number. And the problem with it is the bottom left ventricle, because it's a pretty posterior structure. And if you look, those impulses or the reentry pattern are actually coming from that area, and standard defibrillation doesn't depolarize enough of those cells to actually convert ventricular fibrillation into a normal perfusing rhythm. So once again, standard defibrillation does not apply enough energy to depolarize those cells to convert them. So that's why if you switch the vector around, you're more likely to depolarize that inferior portion of the left ventricle to hopefully convert them. In Dr. Cheska's study, it was demonstrated that in comparison to standard fibrillation, vector change for patients in refractory ventricular fibrillation and pulseless ventricular tachycardia had a higher likelihood of coming back. It wasn't significant, but it was enough to say this is doing something. That's why the EEL core guidelines recommend doing after the 3rd consecutive shock, even those low quality and low certainty of evidence, there does not perceive to be a detriment. So it's a very interesting point at this time, and obviously more studies are needed, but again, the problematic factors is the bottom portion of the left ventricle does not get depolarized enough. Because if we examine the factors of a successful defibrillation, it means we have to look at the current and the transthoracic impedance. So the current obviously means the flow across the myocardium. We have to have sufficient amount of current to flow across the myocardium to hopefully depolarize 75% of our myocytes to convert them to a normal perfusing rhythm. But then it's like, what does this transthoracic impedance mean? So that's actually the energy to pass through multiple chest wall layers before reaching the fibrillating myocytes. So the higher the impedance, the less current reaches the heart. So you can see how these are intertwined. So imagine if you have someone that has a significantly high body mass index. Or what if they have poor pad placement, or they have underlying pathologies like congestive heart failure or cardiomyopathies? You can see that all these factors can change the success rate of successful defibrillation. Because if you have a higher body mass index, or if you have pathologies such as cardiomyopathy or congestive heart failure, that makes it more difficult for the energy to pass through those multiple layers to actually reach the fibrillating myocytes to convert them. The different pathologies that can lead to ventricular fibrillation and pulseless ventricular tachycardia, it's good to review them to see what's the underlying cause and could it impact our defibrillation rate. So if you look, it can all be kind of categorized into inherited causes, acquired causes, and temporary causes. So inherited, obviously that's congenital. If you look at patients under 35 years old, if they have no structural heart disease or known cardiovascular disease, hypertension, and other risk factors, it's a pretty good probability they have something inherent going on if they're presenting in ventricular fibrillation. What if they have long QT syndrome, Brugada syndrome? What if they have channelopathies, disruption of any other channels in their heart, tetralogy of Fallot? This could all be implicated in why the patient's in ventricular fibrillation. And again, if they don't know that, we can't determine if that's actually going on until there's an autopsy and coroner's finding, of course. But acquired causes, what if the patients have cardiomyopathies, long-standing hypertension? What if they do have coronary artery disease or other risk factors? Because if you see someone in ventricular fibrillation or pulseless ventricular tachycardia over 40 years old, you can safely assume they probably have structural heart disease of some sort, which is quite depressing to think about, that over 40, you can start having signs of cardiovascular disease, even though it takes decades for it to actually develop. But if you look at the temporary causes that could be implicated in patients in ventricular fibrillation, it could be electrolyte imbalances. It could be sepsis can cause it, right? What if the patients go into ventricular fibrillation because of drug use, cocaine, methamphetamine, or drugs that prolong the QT interval? This could all be the causes of patients in ventricular fibrillation. But again, if you're a betting person, the vast majority of the time, it's usually from an ST elevation MI or cardiac ischemia that leads to all this multiple ectopic foci in the ventricles, causing that wave-like depolarization that leads the ventricles to quiver, that can actually generate a pulse, and then they go VSA. Especially the larger the infarct, and especially if it affects a significant portion of the myocardium and it's not restored, or you have multiple lesions in different vessels, that could lead to ventricular fibrillation. So now if we examine ventricular tachycardia, obviously the most common reason why patients go into it is from heart disease again. So ST elevation MI, cardiac ischemia, or if they've had a scar from a previous MI or cardiac ischemic damage, that could lead to a higher risk of patients going into ventricular tachycardia. We know this patient on this ECG is a ventricular tachycardia because it's wide, donating, it's coming from the ventricles. There is no P wave, so again, it's coming from the ventricles. It's regular, so that means it's going down the same route, coming from the same spot, which means this is a monoformic ventricular tachycardia, and it's over 100 beats per minute, so it means it's fast. That's why it's ventricular tachycardia. You can also have patients in polymorphic ventricular tachycardia, means you have different morphologies of your QRS, indicating that it's coming from multiple different spots of the ventricles. You can have a certain subtype of polymorphic ventricular tachycardia called torsades de pointes, and that's typically caused by low magnesium levels and from a prolonged QT interval. But again, the causes: acute coronary ischemia, cardiomyopathies, valvular heart disease, congenital defects, drugs, electrolytes imbalances. The causes of VTAC and ventricular fibrillation are kind of intertwined in the same. And if you look at the inherited causes again, long QT, endocrine syndrome, channelopathies, and tetralogy of flow can all lead to ventricular tachycardia. Again, but if we go back and talk about like cardiomyopathies can impede the success of our defibrillation, look what it does to our ventricles, because you have different types of cardiomyopathies where it's hypertrophic, restrictive, or dilated, but nonetheless, the main function of our ventricles is to act as a pump, to pump blood around our body, to perfuse our vital organs. But what happens all the time in cardiomyopathies, this left ventricle wall and septum gets quite large. So instead of, like when we work out right now, we induce a stress to our body on our bicep muscles or our legs, induces a response. The response generates a larger muscle. That's why you need more weights over time, because you need to generate a larger, more robust response over time to get the same effect. However, if you're causing the increased workload of our heart from long-standing hypertension, or if you use drug use over time, such as cocaine, this can lead to a thickened left ventricular wall and septum, but the muscle grows within. So now you can see the reduction in the chamber size of our left ventricle, which main function is to pump blood. And if it can't do that, it will fail. And the problematic factor with these very large walls and septum in our ventricles, they're quite stiff and they can't really work as a pump anymore, so they could fail. And this could lead to patients collapsing, going to cardiac arrest, and causing these shockable rhythms. And again, if the wall's so thick and stiff ventricular walls, successful defibrillation lowers because of this pathophysiology, because the current and the transthoracic impedance would be so high, it would impair the current going across and actually reaching the fibrillating myocytes, which could be so problematic and decrease the chances of survivability in patients. So to kind of connect the success of defibrillation and the cause of tachyarrhythmias, such as ventricular fibrillation and pulseless ventricular tachycardia, it's good to review the main cause, which is re-entry. I'm sure we've all briefly gone over this before, but it's good to examine once again and connect these topics. So for re-entry to occur, you think it has to have this beautiful timing and all these different factors to come in place. So it's quite extraordinary that this can happen, why patients go into tachyarrhythmias. So for one thing, you need a unidirectional block. So normally conductions can be propagated quite uniformly, there is no disruption, but if you have a block from damage, such as cardiovascular disease, from ischemia, myocardial infarction, that can lead to a block in our conduction system. So again, there just has to be physical damage, such as fibrosis, scar formation from a previous MI, or patients who are suffering from cardiac ischemia and infarcted area. And overall, this leads to conduction abnormalities, so an accessory pathway. And then you need critical timing. So the tissues have to be out of the refractory period or before that, and you can also get a premature beat, such as a premature atrial contraction, to happen at the exact right time for all this to work. So you can see there's many different moving parts, and they all have to be aligned for it to actually, for patients to go into re-entry phenomenon. Because if you can see, like under normal circumstances, impulses are quite uniform. They can go down, they depolarize equally. This is why we manifest with a normal P wave, PR integral, QRS, and T wave. And when impulses hit one another, they cancel out. So we look at the different kind of areas of our hearts. We have different transections of our heart muscles. So under normal circumstances, that's our ECG. We have a P wave, we have a normal PR interval, QRS, and T wave. But when we start to have damage from cardiac ischemia or the beginning of a myocardial infarction, the innermost layers are detrimentally affected first, because that's just how our blood supply is. And this can lead to ST depressions, and this signifies a subendocardial injury. So you can see from this little transection of the heart muscle, obviously the damage is the innermost layer, then the broader areas get slowly affected as well. Over time, if the infarct's big enough or it hasn't been restored, or just based on the disruption of our vessels, this leads to a transmural injury, so all three layers are affected. However, this can cause a disruption in our cardiac conduction system, because under normal circumstances, impulses should be propagated without interruption. They should not be interfered with. once they hit each other, these action potentials, they should cancel out. But if you have physical damage from cardiac ischemia or a previous scarring from a past MI, and this leads to fibrotic tissue, that leads to an accessory pathway. So this leads to that unidirectional block. So an impulse can go one way, but it can't go another way. So if an impulse travels down here, there's an accessory pathway because there's literally a damaged patch in the center of the road. So imagine there's a big pothole in the center of the road. Traffic could either go around it if it's one way. But this slows down conduction. It impairs what its normal capabilities are. So imagine the impulse can travel down here, and it goes down to the distal areas, continuing to propagate. But the impulse can't travel down this way because there's a unidirectional block. However, if the impulse wraps around, it can go up this way, then it reaches past this tissue. It's currently not in its refractory period. And the absolute refractory period, again, no matter how strong the impulse or the action potential or impulse is, it will not create a new impulse. And in comparison to the relative refractory period, only the strongest impulse can actually initiate a new action potential. But if this timing, this is this critical timing part, if they're out of the refractory period, that means the impulse can go up and just keep traveling around and around and around and around and around, creating that re-entry phenomenon. That's insane that all these things have to connect at the perfect or perfectly imperfect amount of times that lead to this phenomenon. And now impulses above the site can't take over as the normal pacemaker because this is going so quick. So it's imagine you go to like the busiest roundabout in London, England that you could find, and you're just waiting to try and get in. You can't because there's so many cars and it's going so quick. That's essentially what's happening, and now this takes over as a normal conduction. This can manifest as a tachycardia. So if we apply it to the areas where the bottom left portion, which is the inferior and posterior aspect of our heart, is less likely to convert because standard defibrillation doesn't hit that portion enough to paralyze at least 75% of our cells.